Good morning, everyone. It's a pleasure to be here. My name is Nicholas Cozy. I am an emergency physician, and I help represent, along with Dr. Chris Kang, the American College of Emergency Physicians. On behalf of the college, thank you for this invitation. And Dr. Punch, it was great to see your research presented in Boston in 2021. I'm a pleasure to introduce Richard Caldwell, who is a senior implementation and a military health subject matter expert representing from the Defense Health Agency over the past 5 years, an expert in clinical integration, has tremendous experience over the past 30 years in private and governmental global leadership and emergency management, trauma system leadership. Originally an Army Nurse Corps officer for the past 20 years, if I got that correct, sir, and really focuses on complex service integration, and is really going to be discussing with us implementing this guidance, but also harmonizing it and aligning it. And so without further ado, Mr. Richard Caldwell.
Well, greetings, friends. My name is Rick, and thanks for the introduction. Very humbled to be in front of you all today and share my passion. And move forward. There we go. So my views are definitely my own, not the government's, so please don't get me in trouble. And so before I get started, I'd like to introduce you to some people that are friends of mine, the first of which is an 18-year-old medic in the back of an ambulance about 2 o'clock in the morning up in Wisconsin, caring for 2 severely injured trauma patients. Next one is a 22-year-old nurse working in a cardiothoracic ICU. And unbeknownst to the nurse, that the patient came out with a IVAD, a huge box, and that person didn't know how to use it. Fast forward a little bit farther into the future, there's a 28-year-old captain flying a preemie from Fairbanks, Alaska to Anchorage on a non-medevac helicopter. And lastly, a 40-year-old executive officer managing a combat support hospital with 56 casualties, with only 2 physicians, a couple of PAs, and a handful of medics. So those people are friends of mine because they're me, right? So I definitely look at different lenses when I do implementation. Not that I'm an expert, I made lots of mistakes, but I really look at things with the end in mind. Our objectives today are, I'm going to discuss with you an interesting strategic model that I found the military uses in the JSIDS process, which is looking at capabilities integration. It's not an implementation science model, actually. I'm going to talk a little bit about CPG deconstruction, how I stumbled into it, and how I did it. Not to say that it's the way to do it, but is a way to do it. And looking at the statement that building it, they will come, hopefully. But if you deconstruct it, they will understand. Defense Health Agency, who I represent, I'm a contractor. I'm not a GS employee. I work closely with the Research and Engineering Research Support Division, Implementation Science Branch. Initially, I was the only clinician in a field and a team of really smart young people, business process modelers, psychologists, just people that do implementation. So they adopted me, so I was lucky. At DHA, we use a model that's here, project management, which is important, dissemination, implementation, and assessment. And so really we're looking at modeling our dissemination, implementation, and analysis efforts on the product and at the location where it's being implemented. Let's see here. My first partner that I worked with was the Joint Trauma System, and luckily we have my follow-on partner here. We'll be talking a little bit about the Joint Trauma System, where we looked at implementation of a updated damage control resuscitation guideline across the military health system. And the Joint Trauma System, you've all probably are aware, it's a fantastic performance improvement and learning organization. It collects trauma data from combat casualties and comes up with excellent clinical practice guidelines. What I came up with looking at JSIDS is looking at a non-implementation science model to help me through this, because I'd never done implementation science before 5.5 years ago. I used the DOT MLPFPI analysis model to determine how to approach implementation with clinical practice guidelines. The D is doctrine. So you might think, well, Rick, why are you telling me about military models? Well, it's applicable, I think, to civilian implementation as well. Doctrine are the rules, or sort of the laws, if you will, the regulations, the accreditation guidelines that influence our practice. So your CPG should be hopefully written according to these domains. And for me, I usually get the clinical practice guideline afterwards, and I insert this model. Second, you have to evaluate the organization. How your organization is set up to take care of the clinical problem is important. So the personnel, how are they arranged? Where are they assigned? How many of them do you have? Is it enough? Thirdly, training. What sort of training is required to get, your clinical recommendation into practice? Where is the training? How often is the training? Who's in charge of their curriculum? How many curriculums are there? You have to answer those questions. Material, one of my favorites. Actually, probably my favorite is logistics. So you come up with a great idea, maybe with a material requirement. Question is, what is that? How do you get it? How much does it cost? How do you store it? Where do you store it? How do you handle it? Material questions have to be analyzed prior to the CPG being implemented. Third is leadership, and discussed before. How do leaders approach your clinical recommendation? How should they? How are you going to interact with them? What venues are you going to interact with them? What sort of things do you want the leader to do to help you? You have to be very specific. Personnel. What are the levels of personnel required to do your clinical recommendation? Do they currently have, the training and expertise to actually do what you're saying? Facilities, another one of my favorites that we ignore oftentimes. Will the facilities accept your innovation or your clinical recommendation? One of my favorites was the postpartum hemorrhage project that we were on recently. Came up with an idea of a postpartum hemorrhage cart. Not our idea. We implemented somebody else's idea. But in the military health system, it's very specific as far as space requirements down to the square meter. Has to be taken under consideration. You can't just keep piling stuff into your clinical area without a plan. So it needs to be implemented within the system, including facilities planning. Another favorite is policy. So we do a lot of great things with implementation and good ideas and clinical relevance, best practices. But in the military especially, if it's not integrated with policy in some form or fashion, guess what? It often doesn't get implemented. Not only does it not get implemented, but requirements are not established. So we have a great idea, we all want to do it, but guess what? It's not in policy somewhere. So the bean counters don't fund it. And lastly, integration. Just because we come up with a great idea that it works in the U.S. doesn't necessarily mean that our NATO partners are going to do it either. So it's good to take clinical recommendations and ensure that it's integrated across systems, across not only the medical domains, but non-medical domains as well, and also with our NATO partners in the military. So again, I want you to think, build it and they will come versus deconstruct it, fully understand. The first job I had in implementation science had a very senior, talented trauma surgeon say, just do it, like Nike, right? I know what to do. Here's the CPG, make it happen. Well, that's true. That's great. But what does that mean? Well, Rick, Rick's a simple nurse, right? He has some experience. And if Rick doesn't understand it, guess what? The rest of your team probably is not going to understand it either. So what I had to do, I had to look at it a different way. I had to break it down so Rick could understand it. Well, I approached CPG deconstruction. It was pretty complicated, actually. I like to say that, that I solved the world's problems in a year, but I didn't. All I did is I took 2 CPGs, I broke them down and came up with some clinical guidance that was targeted. The way I did it was I did a as-is process map of the way things were before the CPG. Then I looked at the desired end state, did a process map there as well, established some standardized clinical categories, determined some clinical objectives, determined whether or not the recommendation was for something or actually against something, which is a whole nother issue because sometimes CPGs come out and you're actually saying, don't do this. That requires de-implementation. And then lastly, prioritize the guidance according to the category and the objective. So people know what to do first, second, and third. So that's how we approached the CPG deconstruction, is using this methodology. And these are the categories that we came up with. These aren't really original ideas. These are spin-off of old ideas. If you look closely, it very much is similar to the TC3 categories. I added a few other things too, like prevention of infection and nursing care and monitoring. But if you look at non-physicians and how they approach trauma casualties, they approach them with a mindset that's kind of established with, ATLS approach. That's in their minds usually as a model. So that's how we approached this and came up with these categories. Steps for CPG deconstruction that we did. The first thing we did was we determined the roles of care and the scopes of practice. So the roles of care in the military mean, the role of the hospital, right? So role 1 care is a battalion aid station, far forward care. Role 2, forward surgical team. Role 3 is a combat support hospital. Role 4 is, our main hospitals in the States. So the care that we provide, or the recommendations, looking at damage control resuscitation, CPG specifically, was that there are some differences, right, on how you approach trauma casualty management according to where you are in that area. And scopes of practice as well. So you want to target your guidelines or your recommendations to where people are at, where they've been trained. We bounce that off of what we call KSAs, knowledge, skills, and attributes or abilities. And sometimes what we're asking people to do, guess what? They don't know. They weren't trained. They don't know. A great example of this was far forward blood on the battlefield. Great idea. Plenty of research saying that we should do it. Well, when it came out initially, guess what we found out? We didn't really train medics how to deliver blood, the frontline medics. So we were able to put them in helicopters and send paramedics with them with blood. But if you want to do something in innovation, you have to stop and think who's going to be the one performing that skill. Maybe they need to change their training. We mapped current CPGs and guidance with the new guidance. We looked at capability gaps, provided some solutions, and importantly, we came up with some knowledge products that were targeted to scope of practice and role of care. And that allowed people to sort of hone in on what's most important. They were a medic or a nurse or a physician. One thing about the military is kind of interesting to me is, trauma care isn't delivered by trauma surgeons in the Army. Of course, the trauma surgeons in the Army won't want me to say this, but it's true. Trauma care in the military are delivered by non-doctors. Pretty scary, actually. So we really need to take the time as doctors to really think about what about those poor souls that are out there providing trauma care who are not trauma surgeons. Luckily, when I was a young man, I was adopted by surgeons, thank God. I was, 22 years old, working in an emergency room, and some really nice young doctors were like, hey, Rick, come back in the OR with us. I'm like, I don't want to go back there. It's kind of scary back there. I don't know what happens back there. So they brought me back anyway, and they assigned me to a forward surgical team. Had me, first assist, scrub in, do some closures, They would show me how to help with chest tubes and things. That's really important stuff, because guess what? I ended up in a position later in life where all that stuff came handy. I wasn't an expert, but I was familiar enough to make things happen. And also able to wash out, chest tubes, from people that were dead because we didn't get resupplied. So we washed out chest tubes and had them ready for the next round of patients. You don't get that experience from a book. You get it from people like you that adopt youngsters like me. So what are the outputs for our deconstruction? Well, like I said, we came up with some, I liked the targeted guidance that we were able to do for medics and PAs and docs, nurses. What we were able to do is, through the deconstruction, we were able to dig out the pearls of wisdom and make sure that our knowledge products reflected the most important prioritized guidance based on what the CPG said. So people, in this case, in the slide, this is a COVID-19 in austere operational environment. It's kind of a wild CPG, not trauma-related. But there's a lot of ventilator issues back then. So how do we do ventilator settings in the field? How do we transport patients? What ventilators should we use? That was all created. But if you look at this left side of this slide here, under the blue, you'll see deployed medicine. So that's an app that the Army uses for primarily deployed, medics and PAs, mostly medics, to help guide some of their care. And so we're able to take that CPG and inform in a standardized way in those categories that we came up with, those 12 clinical categories on that app. And people really liked it because they understood it. So we were able to do that, which was well received. And also, in addition to the high tech, we did very low tech back when I was a youngster. We actually made posters of the CPG and posted them in level 2 and level 3 facilities. You know why? Because you can't use your hands when there's like 2 doctors and 2 nurses and a couple of medics. There's no time to do this. It has to be hands-free. So that was well received too. Our deconstruction tool showed a bunch of capability gaps and how to kind of help out with mitigating those. We created a huge web activity of interest. That doesn't necessarily mean that they've been adopted or that we didn't get a chance to measure the outcome, but people really loved what we came up with because it was targeted to the end user. It was prioritized and targeted. And social media increased, web activity increased. So it was a success from that point of view. I mean, not objectively, not outcomes related. Hopefully that'll come in time. So key takeaways from our talk today is that we need to design, with the end in mind, the end users. Trauma surgeons are an end user, right? Just remember, they're not the only end user, please. Deconflict clinical guidelines with the environment, and I like the DOT PFP strategy. Align the clinical guidelines through deconstruction, and remember that CPGs don't live in isolation, and if they do, they die. Here is my contact information, and you can contact me if you would like about anything regarding, CPG deconstruction in the Department of DHA. And I really enjoyed talking with you today. Very passionate about what we do, and I go to bed and I wake up in the morning thinking about CPG deconstruction. I'm very passionate about it. So thank you, Lacey. Thank you very much.
Thank you so much, Rick. And we are going to have to learn from you in the breakouts because we'll keep moving. But Rick means what he says. He's been collaborative and a partner, found him via Google Scholar, and then getting to learn from him since.